So etiology, the numbers are too many. Demographic composition is totally different and difficult to assess the frequency. We still do not have our own data that how much avian has in this country. And the most common etiologies are starting with alcohol. Second is a steroid. Third is idiopathic, traumatic. Traumatic numbers are not that high. Hyperuricemia, varieties of hemoglobinopathy, hyperlipidemia, myeloproliferative disease like Gaucher's, Niemann-Pick, leukemia, HIV. Pregnancy has been also reported, and we do see a good number of patients here in this country. So that's an unusual phenomenon in pregnancy. Smoking, hyperbaric decompression and infection. These are the varieties of causes as far as the avians are concerned. There are so many multiple causes, so it's very, very extremely difficult sometimes to put a finger on the exact etaology of these patients. Quite a number of them are idiopathic. In traumatic, fracture femur reported the frequency is too large, between 15 to 50%. I think it's too much. The range is high. Fracture dislocation, 10 to 25% avian develop. If the reduction occurs within 12 hours, only 22%. If it occurs after 24 hours, avian chances are more than 50%. That's the data coming. What about the cortisone, which is very commonly used by our general practitioners and quacks and whatnot? All Ayurvedic drugs also contains a lot of cortisone. A lot of gym people are also giving some powder for these patients to develop their muscles. So there is some data coming out from the cumulative doses of cumulative doses. So if you look at the data that in SLE more than 20 milligram, some of the is reported is more than 260 milligram is a cumulative days, and cumulative dose is around 45 milligram. So there are different things are we have seen a lot of rheumatoid patients who have on cortisone for a long time. But they don't develop avian, they develop arthritis of the hip, they don't develop avian. So we really don't know. There is some genetic proposition in these patients. So some of them are absolutely sensitive. Only 5 or 10 days of dosage also, especially skin dermatitis, we have seen this patients, quite a number of patients. So it's difficult. What about the alcohol? That has been worked out quite a bit by many people. If you have a zero alcohol, then it's about less than 1% chance of avian. If you have a 400 ml per week, so 3.3, 400 to 1000 ml is 9.8, and more than 1000 ml, I think you require a weekly dose, that is not a daily dose, 17.9%, about 18%. So definitely it is related to the dose, not like something like a cortisone, but this is definitely related to the dose. We are aware hemoglobinopathy of sickle cell disease, HbS is almost 4 to 12, and if you have a SC disease, it's much more higher. I think we will take some lecture on the sickle cell later on, and we will discuss a lot of avian in this group of patients. This is not this will not be time for me to discuss only sickle cell. So I'm going to, in general, give an idea of avian. And sickle cell does have a belt in Gujarat, so we do a lot of sea population. What are the risk factors as far as the risk factors are concerned? Etiology does not have major difference in progression. Age, gender, no correlation progression. FICAT 3 over the age of 40, rapid progression. If patient comes with FICAT 3 and he is 40, 50, these are the people who are likely to progress very rapidly. Segmental collapse more than 4 millimeter, rapid progression. And the lesion area more than 60% are all AP and lateral, both they collapse rapidly, means absolute rapidly. Within 6 months to 1 hour, they will come to the surgery. What about the little bit of pathophysiology? The main is the two problems. One is a vascular occlusion. Second is vulnerable microcirculation. There may be abnormality in the circulation of that patient, we still don't know. And the final answer to both this condition will be cellular death. And most studies are animal. We do not have any human study as far as this is concerned. So if you look at here, that is traumatic etiology, direct vascular damage. Here is the intravascular coagulopathy which we develop. That is a thromboembolic phenomena takes place. And here the alcohol and cortisone, they are going to be an extravascular compression because of the adipose tissue and other thing which causes indirectly they will have effect on the blood flow, no question. Everybody is going to come on the, all three factors are going to come with the occlusion of the blood flow. So whether it is a direct injury, whether it is thromboembolic or it is an extracapsular, this is important for three different pathologies, but they will lead to a blood flow. All of them ultimately lead to blood flow decrease. Ischemia, first will be the death of the osteocytes, and there will be a necrosis. The repair will start, and during the repair, if the repair is not going to be adequate, the loss of structure will take place. And if there is osteoblastic and if both are not going simultaneously, chances of getting collapse are very high. So just again coming back to trauma, vascular complete interruption, intravascular coagulopathy which develops, and alcohol cortisone will induce extravascular compression leading to reduction in the blood flow, ischemia, death of osteocyte, necrosis. And that is the position. So all these theories, the direct cellular toxicity, coagulopathy, coastate, hyperlipidemia with fat embolism, venous interruption, and abnormalities and elevated blood barrier pressure. This is one of the theory which is So what about these theories, the pathogenesis? None of the theories can fully account the varieties cause. None of the theories, whatever we describe the 3-4 theories, none of them theories can fully accountable. Most patient, now look at this, most patient with risk factor, they never develop AVN. They are taking alcohol for years together, for donkey's years, they will never develop. Cortisone, I told you, rheumatoid patient, they will never develop. Okay, the patients who are on head injury patients, so they many 90% patients don't develop. Many patients with identified risks develop. Non-identified risks, they have identified risks, but they will not develop AVN. So we don't know that these theories, whether they will be true or not. Process looks to be more multifactorial and not only single cause. So that will be the answer as far as you are concerned. The AVN has got multifactorial theories as pathogenesis. It is not one theory. What is the incidence? 5 to 10% THR for this are reported all across the world. Between the age of 40 and 50, 50% are bilaterals. A lot of reports say that is 75 to 85% are bilateral. More than 20,000 cases the USA does, males into 4 to 1. Have we got our own data? So Indian Society of Hip and Knee Surgeons has its own data, which is a limited data, but we are in the process of creating our own database. And 48% of total hip operated in this country are AVN. So this is a very important information to you. Again, I'm repeating, Indian Society of Hip and Knee Surgeons has a registry in place. Last 10 years data we are collecting, and 48% of our patients are AVN. Something like, again, in the Korea also is the same, AVN rate is very, very high. So we have a large number of population of avascular necrosis. This is one important information to you. How do we clinically? Pain incidence, chronic, sudden pain is not common unless he has got overactivity and gets a microfracture. Most of the patients have a groin pain and is a ringing groin pain. They are not that disabled. So that is the reason they don't come early, but they come in a way, or most of the time in a late phase. Many patients have referred knee pain, and that's why most general practitioners will take the knee X-ray and did not bother to look at the hip. So this is a commonly again missed condition from the general practitioner. Even the same thing with orthopedic surgeons. Sometimes they refer pain to the knee, but most of the time you'll concentrate on the knee. Buttock pain less common. Pain on activities, definitely. Pain on rest pain, usually they don't have the rest pain. So pain on activity is one other important factor. Early physical signs are early loss of flexion and internal rotation. Once that is the rotation, very important, that is called as a log roll test. So we do, actually this is mainly due to the pain due to the active capsular synovitis which develop. They have a joint fluid inside, and that is the reason the rotations are painful. That's called as a log roll test. Then they develop a loss of abduction, second important. Active SLR provokes the pain. You ask, give a resistance or active SLR, they will complain the groin pain. This is another important test. Differential rotation is a very late stage when the head is completely collapsed, is irregular. Usually they don't have shortening unless they got very gross destruction and subluxation. Then only they will have developed shortening. Otherwise, majority patients don't have much major shortening. Chronic symptoms may develop, but if the patients are not treated or they are not reported, so they will develop flexion deformity, lateral adduction deformity, which is common. Flexion adduction is a common deformity which they develop. So most important is log roll test, limited abduction. These are two important, and third is active SLR. So on radiographs, how do you get into that? I'm going to repeat little radiograph twice, so you will be understanding, because and fortunately I have a very good collection of radial X-rays. So I will go to repeat twice so that you will remember all the signs. First is mortal sclerosis. There is possibility sometimes radiolucency. So that is the time bone resorption, either bone resorption and sclerosis. Then once it is developed, then you develop a crescent sign, which is the most important, that is called as a subchondral fracture line. This was actually described by Solomon. It was actually my examiner. It was my examiner for MCH. Then subchondral, once the crescent sign develop, then you have a subchondral collapse. Then once you get a collapse, then you have got irregularity between the head of the femur and the acetabulum. Then you start a degenerative joint disease and complete collapse with arthritis. That is the way it moves. So first is mortal sclerosis or radiolucency, bone resorption sclerosis, crescent sign, subchondral fracture, degeneration, and then collapse, and then arthritis. So we will see everything. This is a patient who has looking absolutely normal, except once you very carefully see, there is some amount of radiolucency under the subchondral plate, like something like a crescent, mild crescent. Or you have, if you look at this here and this here, there is a sclerosis, very important sign. Look at this here, trabeculae are seen. Here we are not able to see the trabeculae, and level profile, very minor, very subtle subchondral sclerosis, subchondral crescent sign is there, which I'll show you in next X-rays. So this is very early. Another patient, look at that, it looks normal, except if you compare both the sides, there is mild sclerosis between the femoral head, which is not appreciable unless you know it. Then you develop a subchondral sclerosis, subchondral crescent sign. This is very advanced crescent sign. You see, this is subchondral fracture which has taken place, and the articular surface is still normally there is intact, and the fracture occurs just below the articular surface, and that's why it's called subchondral fracture. Once this sign develops, the patients don't do well, so they are gone into advanced stage, and that we will discuss how the treatment will be. Treatment in these patients are different, treatment in other patients are different. Sometimes you have a cyst. So sometimes you have a cyst. This patient has opposite side cyst. And now the head is collapsed. Look at that, head is collapsed. And sometimes you get shortening because the head is collapsed and it's superior migrated. That's why this patient will have some degree of shortening, 1 to 1.5 centimeter. So this is the collapse, and this is completely destroyed head. We see sometimes rapid destruction, and sometimes you have to keep in mind tuberculosis. So the next stage after the collapse is secondary arthritis. Secondary arthritis is always associated with a joint reduction, joint space. If you look behind, joint space will be all right. Here the joint space is reduced. You have osteophytes on both the side. You have seen both these patients. You have a large cystic lesions here. You have a segmental collapse. You have quite a bit of degenerative. This is a very advanced degenerative in AVN. So this is the way you develop an end stage arthritis of these patients, from early collapse, crescent sign, collapse, then still acetabulum is all right. Now acetabulum is not right. One more important thing which we'll discuss in radiology, how to measure carbon angle. This is a very important carbon angle. It is known as an avascular necrosis angle. Many of us exactly do not know how to measure this. You have to use the most circle of the head, and you take the center and not the center of the lesion, not the center of the lesion. Look at this, center of the lesion, you can't take it. You have to take the center of the head, then draw a line in AP, most lateral margin and most medial margin. This is called A, and lateral X-ray also has got the same phenomena. You have to make the center. Many orthopedic surgeons do not know how to measure this carbon angle. You have to get the center of the head and not any other area. And Mohs circle, you have a Mohs circle scale which you have to use it, or you can use a protractor. So this is the way the angle is measured. Now, why important is, very important is, why this angle are important. If you look at this, he described small and medium and large. Today also it is relevant. We still follow this gentleman. So what is meant by small? So if the combined angle is less than 130, that is a small. These patients extremely do well with core decompression or bone grafting or any stem cell, whatever you want to do it. Also, these patients will do well with conservative approach. So 130 is the limit of the angle. The medium size is 170. So the angle is, the necrotic angle is very large now. And large angle is more than 200 is the large. These are the patients who will not do well. So carbon angle is important. A plus B, center of the head, important. Now we go to, there are 2-3 classifications. They are a little confusing and they are got intermixed. Even I'm quite a bit confused. But I will try to make it little simplify and try to give some answer to you. Because every examiner will have a little different approach. And you might say stage 3, the examiner will say 2. That I'll tell you why he is going to. Because there's a lot of problem of this Ficat classification. So Ficat-Erlach classification. 0 is normal, that is a silent hip, that's a normal hip. Grade 1, stage 1, inconspicuous abnormality or minor osteopenia, which is either penia or maybe sometimes slightly sclerotic area. 2, sclerotic or cystic, there are different varieties. In that sclerotic, we divide it into 2. 2A, focal radiological changes. B, now he's come into the crescent area, crescent sign without flattening the femoral. You get a subchondral fracture, but there is no collapse. That is the one earlier I just showed you on X-ray, which I'm going to show you again. Okay, so that is 2B. And if once these patients are coming in 2B, they are going, from here the problem starts. Up to here, we are not worried. We can do something. 3, flattening of the femoral head. Once the crescent sign develop, fracture occurs, flattening occurs, femoral head collapse. Joint space is normal here, and last, which I showed you, space is not normal. That is stage 4, femoral head collapse, arthritic changes, and you have changes on the acetabular side. So both the sides are changed. Yeah, that is important. There's some people in this third. The people sometimes do a bipolar arthroplasty because they feel that the acetabulum is normal. There are some reports from our Indian continent, which we will discuss. So that's why this is an important staging as far as this is concerned. But I'm not very keen that we should be able to do a bipolar because those are very young patients. So this same, again, I'm repeating this classification just for your 0, that is asymptomatic pre-radiographic, nothing. Stage 1, there are symptoms, very mild symptoms, radiographs are looking normal on X-rays. MRI and bone scan are positive. Bone scan usually is a cold, which I'll tell you, cold spot, not a hot spot. If it is a hot spot, that means you have gone in stage 2 and stage 3, stage 4. So it has to be cold area of that exactly small area of avian. Stage 2, mortal sclerosis or radiolucency, trabecular alterations. Here there is no collapse are taken. Cyst may present or may not. There is no fracture. Now he described, here actually he described in stage 2 subchondral fracture. Now he describes Ficat, again he describes slightly different. Crescent sign is present with subchondral fracture. That's why there is a lot of confusion between the 2 and 3. Loss of sphericity, segmental collapse, sequestration, 4 is osteoarthritic, which I told you, both sides are osteophytes. The disadvantage of this picket, lack of quantitation in grade 2 and grade 3. Inter-observer error is 17.5%. Inter-observer and inter-observer between two errors are 40%. And that's why the examiner may give some not between 2 and 3 sometimes. He may not. He may give a grace point because there's a lot of error which is going to take place. So it just relies, FICAT only relies on plain radiographs. That's why it is important for us. It is not only FICAT. We have to consider other classifications like MRI and other things which will come to it. So I'm just describing again for repeating for you. Stage 1. Stage 1, there's a little sclerosis here. Stage 2A. Here there's almost clavicular okay, but there's a gross sclerosis in A. And B, that is one what described as a subchondral fracture. If you look at it very carefully, are you able to appreciate, all of you?
Yes, sir.
Subchondral lucency, that is a segment, and that's known as sectoral sign. It is usually present, usually low on the frog lateral. AP X-ray are usually not, you are not able to see, and that's why in avian frog lateral X-ray is absolutely important and mandatory, which I forgot to mention. Stage 2B, again one more X-ray. Here much more clear. Can you see this? There's a sclerosis here, and you look at the subchondral fracture. Right, more than 60% of the femoral head, and these patients will not do well. And what on the table, they just peel off. You look at this, one of our patient just peels off the articular cartilage, just peels off, and you see complete necrosis of the femoral head there inside. It is more than, and if you do a cut section, which I have not put it, so almost more than half the head will be avascular. And look at that. And this is another little larger segmental with a there is a fracture which has taken place here, subchondral, and you see the radiolucency. Very, very classical phenomena of crescent sign and pathological fracture inside. Stage 3, you have a collapse. Look at the established normal for this patient. Even lateral X-ray, there is no osteophytes, looks all right. There is some amount of synovitis which has taken place. That's why it is a little subluxated as compared to this is a teardrop. Head is slightly subluxated, maybe 2 or 3 millimeter lateral. This is because of they develop a synovitis. So stage 3 acetabulum is normal, where a lot of people, if elderly population, other thing, you can do a bipolar orthoplasty. Possible is there. So that is stage 3. Stage 4 is completely arthritic. Look at the osteophytes. And gross arthritis. Look at the joint space. Very important. Joint space is completely reduced. So that's the way we discuss all avians. This is, I'm going to skip. So the next classification is ARCO, that is Association of Research Circulation Osseous. This is a group which did a lot of work actually about 15 years back. I think a lot of people from the countries, they came together and made this classification.
Proceed, sir. Proceed.
Yeah. So this the Association Research Circulation Osseous. The asymptomatic is that is the stage 1 symptoms, normal CT, normal X-rays, early changes only on MRI, very subtle changes on MRI, and then you may not be able to see a geographic distribution, which I'll show you what is meant by geographic distribution. The stage 2 symptoms are much more. That I told you this, either you get a sclerosis or you'll get a cystic changes. Diagnostic finding on MRI, that is stage 2, will be a very diagnostic feature of what is called as a geographic feature, double density sign, and few other things. 3, crescent sign, less than 15% articular, that is A. B is called more than 15 to 30% of that's the size of the femoral head, and more than 30% is the 3C. So the crescent sign is important and the size is important, very important. And if they are small, they will do well. They will do well. If the crescent sign is larger, they won't do well. The 4 is stage 4, head collapse. In that also they have mentioned A, B, C, less than 50%, more than 50%, and more than 30%. Same way as in 3. Then the fifth one, OA, narrow joint space, established stenosis, marginal osteophytes. Then lastly, extensive joint destruction. That is the way ARCO staging goes on. This is a classification on Pritzker classification, and also it is related to MRI finding and also as well as the other plain radiographic finding also. So in this Pritzker classification, there is a stage 1, 2, and 3 which is divided into A and B. Everywhere it is less than 30, more than 30. So it is easy to remember, my dear. Okay. So here the structure is absolutely here. The MRI is abnormal in all these MRI findings in stage 1, 2, 3. Here the structure of the plain radiograph contour is normal. The contours start getting abnormal as far as this is concerned, and that's the way we classify that. So there's one more classification, Shimizu classification. This classification based on MRI, which defines what is the extent of vision, location of the. A lot of people did not do the location. Actually, he is the person who looked at the location and intensity of the abnormal segment of the femur. So he looked at the extent, location, what intensity. All 3 factors he looked at. What is extent? What is the amount of femoral head problem in a coronal femoral head images? Location, he wanted to find out weight bearing or non-weight bearing. That's another very important. And intensity is also important. Intensity signal on a coronal T1 spin echo. That was the way he described the classification. And this classification is something like this. The extent, location, intensity. Intensity is T1 W spin echo on echo. That's another sequence which he used it. So in this ABC. So A is a very, very small lesion. Extent is less than 1/4. It is 1/4 to half and more than half. Here the location, area of the location is less than 1/3, 2/3 up to 2/3, more than 2/3 of femoral head. And the intensity depends on this. And he described as alpha, beta, and gamma. Alpha was a high intensity, beta was a mix, and this was a low intensity. That means it's much more advanced. Disease is much more advanced. That way, this classification on MRI classification is. So today, MRI is gold standard. There is no question about it. So it is a classically anterior superior lesion, well demarcated, but inhomogeneous, which I'll show you what is meant by inhomogeneous. It is not homogeneous because the activity is going on in a different way. Somewhere it is repairing process, somewhere it is new substitutes are taking place. That's why it is inhomogeneous. T1 image, low signal intensity. T2, high signal intensity. Inside a low signal line, it's called double line sign. If you see a double line, 100% you can vouch that this patient has got AVN and not transient osteoporosis, not any other cause. This is pathognomonic sign of a double line sign, which 2 or 3 MRI will show you. High signal, whenever there is a high signal intensity, that means there is some creeping substitution. That's a granulation is coming in between that two. That is that area will be high signal and opposite side will be low signal on the both side, and there will be central high signal area. And all these infarcts are geographic distribution. Geographic distribution is nothing but map, any country's map. It is not a slate, so it is zigzag. That's why it's called geographic distribution. So 2 important signs for AVN, geographic distribution and double signal density. You can tell 100% this is AVN. So this MRI looks perfectly normal in T1 weighted. But now look at this. This is T2 weighted. This is the most early sign. Here now there is no geographic distribution has taken place. There is no segmentus collapse. There is no subchondral fracture. This is the most early sign, stage 1 in whatever there is a subtle sign. This is the way we pick up. This is a very important sign. Very important sign. And this is on coronal. This is on. Look at this. This is a bright white here. This is the time you need to pick up this. This is the time you need to pick up this AVN. Absolutely important. Bone scan. Decrease uptake in early stage. That's cold. During late stage, there's no role at all. This might be useful, especially in assessing the status of multiple joint like SLE and all other things. But today, we don't do any bone scan as far as this is concerned. Some patients, AVN patients, do have a knee pain also associated. Also, sometimes they can develop osteonecrosis of the femur, distal femur, upper tibia. This is one patient which I had actually had a. You look at that. That's a patient who had a multiple. Sorry, this has a bilateral AVN segmental X-ray was looking normal. Even after totally, this man was not happy. So I got it done there. So we saw that. This is a T1 weighted, this is a T2 weighted, and that's the way sometimes do have osteonecrosis of the femoral condyle. Now I'll tell you what is now in MRI T1 weighted. Look at this. This is geographic distribution. It is not like that uniform. Look at this. Is non-homogeneous. Here it is little darker. Here it is different. It is little red. This signal is different. This signal is different. This signal is different. This signal is different. So it is inhomogeneous. Geographic distribution. Look at this. Classical. So that is the way we describe this. And this is a pathognomonic sign of AVN. That was T1 weighted. This is T2 weighted. Look at this double density sign. This is a darker here, and this is the granulation clipping substitution here. Please do not miss this. In exam, if you draw this diagram, probably examiner knows that this is an important sign for you. Geographic distribution, double density sign. So this is a very classical in AP and as well as in other coronal plane. So that's the way we see this double density sign. We need to differentiate sometimes transient osteoporosis. Very, very common again in this our country because of calcium, vitamin D deficiency, maybe some other causes. So all these patients, we must screen it properly. So we can differentiate transient osteoporosis from AVN by two important signs. One, I told you, geographic distribution. Second important is double density sign. If both are not there, probably you are dealing with transient osteoporosis, and these patients will do extremely well. This is one such patient in my clinic. X-rays were normal. Look at that. This is a T1 weighted image. Look at this. This is homogeneous. It's not a non-homogeneous. And very, very clear crystal margin. Is no geographic distribution. And T2, completely bright and the edema is going right up to the subtrochanteric area. Any edema going below the subtrochanteric area, you have to keep in mind there's a chances of this patient has gotten a transient osteoporosis. And then you investigate by calcium, vitamin D3, all other tests, and you correct them. Sometimes you may not bet any cause of it. You can just keep them off weight, put it on walker or crutches for 6 to 8 weeks and just supplement with calcium, vitamin D3, B12, whatever you want to. They will do extremely well and they are very happy patient. This is a patient who has seen T1 now, T2 weighted before treatment. And look at this after 3 months or 6 months, maybe a year, I don't know. This is, you look at that, completely resolved. Even with the spin T2 weighted spin echo, completely resolved. So these patients will do extremely well. So you need to distinguish between AVN and transient osteoporosis. Crystal clear? CT role. It has very limited role. We used to do about 20 years back. We had no MRI at that time. We used to do it. But this small indication, may be useful only in suspected late pre-collapse and from early collapse. Very small subchondral fracture cannot be picked up on MRI. So look at this, because you can take the 1 millimeter cuts also in these patients where MRI it is not possible. Minimum is about 3, 4, 5 millimeter or so. So here we can pick up very small, subtle microfracture, that is a crescent sign or subchondral fracture. So that's the only role as far as this is concerned is on the CT scan. Management, medical management, surgical management, medical indications, alternative to surgery. Many patients will not like surgery or decompression in early stage. So you have a choice of medical management. Small asymptomatic lesion, which are very small, peripheral lesion, maybe 10% of the femoral head is involved, maximum is less than 20%, 30%, are good patients for medical management. Suppose patient is not fit, or patient is some patient who is on a high dose of cortisone, plus is a renal transplant, liver transplant, is a poor medical condition. We may not be able to operate them. Some patients have already come with a decompression and some other procedures. So we have no other choice and wait till that time you can start medical treatment. So these are 4 indications where we can start medical management. Certain type of procedure, decompression, bone grafting, osteotomy has done, still they are painful. So you can just put them on a medical treatment. So what is this medical treatment and considered? Limited weight bearing, stick, crutches. Many of our patients do not want to use this stick and crutches. I think it's very important that if they start using this, I think the pain factor goes rapidly and they are very comfortable. Many patients will not come to surgery on the table. Weight reduction. But my personal feeling is most of the time these avian patients, they are not overweight except the patients who are on large dose of cortisone. Most of the patients, alcoholic patients, are very thin, lean. Pain medication only for short duration. We don't want to damage kidney and send it to nephrologist. Biphosphonate. I think that's a great work. Everybody in India should know Dr. Sanjay Agrawala. He is international repeat on avian. He is the highest authority on biphosphonate drug. So he has got a huge number of publication. He was my colleague at Hinduja Hospital. We are very close friend, and he's got a great work. So everybody should know Dr. Sanjay Agrawala's work on biphosphonate. There are a lot of publications. You will have to go through 1 or 2 publications, but I'm going to give you what formula he uses. It can delay the collapse. He has got now 10 years follow-up of his patients on these drugs. It can delay THR quite a bit, a number of them. I am using right and left of Osteophos. I'm maybe one of the largest user next to Dr. Sanjay Agrawala. Statins, I think they have gone out now. Aspirin is still people try to use it, but I don't know about the role. I never used this aspirin. So this is the work of Sanjay Agrawala, use of adult-rotated treatment of avascular necrosis. This is JBJ's publication 2009. What he initially started using a 70 milligram, but now we are using adult-rotated 30 milligram twice a week. Twice a week, that is a Monday, whatever the convenient is. I ask them usually on Sunday and Thursday. Usually has to use for 3 years. It must be supplemented with calcium and vitamin D3, especially calcium. D3 may not or may, depends on what is the value of the D3. But this drug does not work. One important finding for all of you, does not work without calcium. Recently, for last 5 years, he has added a new protocol of IV zoledronic acid once a year, adding to the adult-ronate. Not only zoledron. Zoledron you use once a year for 3 doses and also uses adult-ronate. So there's a huge work of Dr. Sanjay Agrawala. Next is, we will go to, I'll just a minute, I'll tell Chinu Kaka. Kaka, मैं जरा busy हूँ, phone करता हूँ. So we are going to discuss now core decompression, various vascularized, non-vascularized graft, couple of osteotomies. I'm not going to discuss THR and resurfacing. I'm just going to get just 1 or 2 slides. Most important I'm going to discuss is the decompression and vascularize a few other things. We must know a little bit of blood supply of the femoral head. The lateral epiphyseal vessel, which is coming from the medial circumflex. This is the most important vessel. So lateral epiphyseal, all these lateral epiphyseal vessels coming from the medial circumflex. The second is the lateral femoral circumflex. That's a lateral femoral circumflex. And artery of ligamented teres, which is a very, very small contribution. Just a rough idea. Regarding the core decompression, we used to do a large drills, which I'll tell you what is the size we have to use all this. But today, we are using actually core. So why important is, while drilling, we are compressing the other bony areas which will not allow the osteogenesis to open up. That's the reason we are now using the core, very, very sharp core, so that the area is very well maintained, and as well as it opens up quite a bit. It will not compress the bone on the side, and it will not block the vascularity. And that's why refined core is much better than your drill. And it got all varieties are available. So you have to get right into the direction. Maybe you have to use a guide wire on that, and then you can use a core on that. That is much better. And the usual guide wires are very thin, usually 2.3 or 2.2 millimeter guide wires. And then on that you can use a core. Look only not epilateral X-ray, which is a common mistake done, because these lesions are slightly anterior superior. So you cannot hit them. So most surgeons go in the center, and just for namesake they do decompression bone grafting. The dead area, you have to open it, otherwise it does not work. So you look at the image, continuously move the image with a 360 degrees all around and try to hit the lesion. The lesion should be right in the center, and then you can get the other areas done. So that is important for you. So now we got slightly advanced core decompression or extended core decompression. That's a drill use larger one. And then there are special drills which you can go on the sides at multiple levels with some amount of flexibility is allowed, so that you are able to hit the other area through the same core. So through same core area, which is allowed to do it. So what is our indications for core? So this international classification, stage 1 and stage 2A, small central lesion, peripheral lesions are not accessible. Very young, non-obese patient should not be on steroid dependent. These are good patients as far as decompressions are concerned. So stage 1, 2A, small lesions, young patients, non-steroid dependent. Simple surgery, low complication, subsequent THR has no problem. You can straightway go for primary hip. What is the theoretical advantage of this decompression? Relieves intraosseous pressure caused by venous congestion. There's hypertension, venous hypertension, not arterial. We want arterial hypertension. Improves vascularity. Possibly showing the progression of the disease after this procedure. What the results of decompression are better than non-operative? Best results I told you, stage 1. More than 30% will need THR within 4 or 5 years of post-decompression. So 60-70% in stage 1 they will do it, but 30% are going to come back with a collapse. Now only core decompression or bone graft. So a lot of people in stage 1 and 2A will do only a decompression, but many people like to put some bone graft, the osteogenic material. So we remove the dead bone, replace with some graft, varieties of graft we'll discuss, in stage 1 and again stage 2 only. So we don't go beyond this, as considered decompression, bone grafting only in stage 1 and stage 2. Drill size, 8 millimeter should be the central drill, and the minor drill should be 3.2 to 3.5. A lot of people are, instead of using the other drill, they use a Steinmann pin. So again, I told you, instead of drill, that doesn't open. Instead of use a Steinmann pin also it is possible to use instead of drill. So major drill is 8 millimeter because you need to pass graft. So core, I told you, core is better rather than drill. So we can use a 8 millimeter core diameter. And one important thing I forgot, the entry point should be just below the trochanter. Do not do in subtrochanteric area, fracture will take place. Subtrochanteric fracture will take. This is one of the complications of decompression. Bone grafting, the complication, sometimes you are not properly aware, you are not using a proper image, you will damage articular cartilage. And once you damage the articular cartilage, patient develop a synovitis, and they are very painful. Infection still possible, and subtrochanteric fracture has been reported. But now today, everybody has become very cautious. So we exactly do now just on the crest of the intertrochanteric, just below where the vastus lateralis get attached. That is the trochanteric ridge, and that is a cancellous bone also, and it is a broader bone, and that's why you will not get fracture. As you go down, the bone becomes thinner, and it is only cortical bone. So this is one of my patient actually, who came to Shalby after 20 years. He started hunting and came. So last year he came to meet me. I had done this 20 years back, decompression and bone grafting for the iliac crest. And look at that, completely normal, absolutely normal as far as this is concerned. So this is one of the longest follow-up I do have. And actually, to be frank, to tell you, my boss was the first person to start this procedure of decompression and bone grafting. Unfortunately, he did not report anything. Anyhow, next is, that is from the trochanter grafting. Now you can graft through the femoral neck window. So this is, and you use what is called as an anterior approach, where you want to keep the vascularity of the behind, and you can make a small window just below the articular margin, between the articular margin and the neck, exactly junction. Don't not in the articular surface, just below that, and make a window, and through the window you can do the grafting. But this procedure has not worked with many people's hand. Some people thought that they did a grafting through the articular window when the lesions are larger. There's already subchondral fracture has taken place, there. But I think this procedure also has not worked well. It is also an anterior approach, and you have to do what is called safe dislocation, Gans approach, which I told you last time. So these are non-muscular graft. Typically, you have to use the stud grafts, iliac crest stud grafts under the articular, and also augment with cancellous graft to improve osteoinduction and also osteoconduction, both. So structural as well as cancellous bone. So what we did that is I just showed you one of the slides that articular cartilage was peeled up completely. That is the way we picked that articular cartilage. Then use the high-speed burr. We remount the complete area, make a cavity, nice cavity. You open the cancellous bone all around area, and then put a stud grafts, iliac crest, and then side on the chips and the side, and close that window with that same articular surface, and you can apply actually fibrin glue at the level of where the cartilage gets packed up. You can use the fibrin glue. Sometimes people started using a bone cement, but this is not biological. It has failed rapidly. So we no more use this system. This is one such patient who had a collapse, and we had to drill this area, bigger drill, use the syringe, and inject bone cement. One of the patient actually I operated was the cement had come out through the surgeon was not very careful, and this cement has come through the actually femoral head, and it was abutting against the acetabular, and he came the hip was very painful because it was abutting on the acetabular cartilage. So this is one of the complications can occur. So the other is non-vascular fibula graft. This was very commonly done in the country, but I think it's not that have not got good results, and we don't have actually long-term follow-ups and controlled trials. But a lot of people use fibula graft in this country. So this is one of the procedure commonly described, and this was very popularized by Dr. Babulkar, Dr. Nagi, and few other Dr. S.S. Yadav. These are the three people in the country who popularized this fibula graft. Vascular fibula definitely. Vascular graft definitely has one of the very important role today in modern orthopedics. The local muscle pedicle, there are two types of graft. One I'm describing is local muscle pedicle graft, which is different from the fibula. So don't confuse. I'm going to show you also. So local muscle pedicle graft, we use the anterior superior iliac point with a deep circumflex artery and iliac is part of the iliacus muscle. It does not require vascular anastomosis. It does not require vascular surgeon. The orthopedic surgeon can do it if he knows the exposure from inner side. So this is the way it works with usually anterior split incision. You see, this is a deep circumflex iliac vessel. That's exactly on the iliac crest it comes. So you take a huge chunk of iliac crest. Automatically, you don't have to identify vessel. Just you have to just know the large piece and just strip out the iliacus muscle. You will be with this pedicle, and you look at the crest and as well as the part of the iliacus has taken. And that's nothing but the deep circumflex iliac vessel, and just put into this area wherever this avian area. You have to open it through the window. You have to use a neck just above the neck. That's the article I showed you, the window trapdoor entry. So where you have to use that trapdoor entry and open it up and then push this graft inside. And also there is iliac crest there. You can take some cancellous bone, also pack that area. So it can be structural as well as osteoinduction, osteoconduction. The next one is vascular graft. This is very commonly done actually in Japan. We've got the largest experience, or now they are following almost 25 years to 30 years of follow-up. But this requires microvascular man. The orthopedic surgeons usually are not able to do it because you require vascular surgeon, because the anastomosis is very important because these vessels are only 3 to 4 millimeters only. So we take the peroneal artery from the fibula and we have to anastomosis with ascending branch of lateral circumflex. So this is the ascending branch of the, this is the femoral vessel, this is the profunda, and this is the branch of the lateral circumflex, and this is the peroneal artery with attached with a fibula, and this is the anastomosis area. I did actually a couple of them when I was in Mumbai, but it too used to take about 6 to 8 hours, and it was very tiring. I did very few of them. I don't have any results, but this is one of the patients where I just saw that. And this is very important that you have to put a K wire actually. This fibula should not slide back. Otherwise, the anastomosis get a king. Another important finding. What is the size of the fibula? Should be 1 millimeter larger the hole should be, because when you put the fibula inside, it should go with a hand. You should not hammer this. If you hammer, you will get a kinking of the vessels, or you will get a periosteal damage. Some muscles are also attached to that. That is one important trick. Second important trick is you have to put a transfixation wire. These are two important tricks of this vascular fibula graft arm. Only problem is that donor mobility is about 8 to 10%. You can have some peroneal palsy, weakness of the peroneal muscles. Patients do have this. So this is one of the price you have to pay. But this is an excellent operation as far as the vascularized fibula, stage 1, stage 2. This is one patient I operated. One side was the vascular fibula was done. The other side was only simple decompression. And this patient, even though minor arthritic, look at the collapse has not taken place, and this patient was totally asymptomatic. He wanted me to do on this side, so this side was the THR was done for this patient. So this procedure does work. So the newer implants are coming in the market, but we still do not have enough data and enough experience. So titanium implant, which can ingrow the material. This is the type of material which you can use it. Titanium is supposed to produce some amount of osteogeneity, attract the osteoblast. So this will allow, it will stop the collapse of the femoral head. These are the implants, titanium porous coated implants are now available. They are available actually. The next is the stem cells. The big yoke came about 8 to 10 years back from the stem cell. But today we still are not being very comfortable using a stem cell routinely across the country. So Indian government had actually stopped they have stopped actually the stem cell, and now recently, I think 1.5 or 2 years back now, the release has taken place after controlled trials have been done in 2 or 3 centers. One of the center which is everybody should know is the Chandigarh Center. Ramesh Sen was one of the investigator, was there in the stem cells. So just basically you all know that blastocyte, that is totipotent cell, these are the basic cells which are now converted into pluripotent cells, and from there the differentiation takes place. Look at this, the differentiation is reverse here. There is possible to go back. Once you cross this stage, there is no possibility of de-differentiation. Can't go back. You can go forward, cannot go backward. So this is the only stage, ectodermal, endodermal, and we are just related to this skeletal and other thing, or the mesodermal as far as we are concerned. I'm going to not go into the detail, but 2 or 3 important things I'm going to take you into the stem cell. Still, there is no enough data available as far as most of the countries are concerned. Forget about India. So this is something, stem cells. This is the gentleman, Harnigu was the gentleman who actually described the stem cells. So bone marrow aspirate concentration was initially bone marrow aspiration concentration. It contains varieties of cell, but if you look at the very detail, there is a low concentration, low proportion of the stem cell. We really don't know how many cells are there inside. We may not, and that's why we may not consider this surgery as a genuine stem cell therapy. So the population of stem cell is very, very low in this marrow. And whatever the cells, you are expecting these cells to survive, most of them will die. Number 2, if they survive, they should be taken into the recipient area and they should get differentiated in the bone forming cells, because stem cells have to be converted into osteoblast. Then only the new bone will start. So you want the stem cell to survive and differentiate into bone forming cells, that is osteoblast, from osteocyte to osteoblast. And we have no proof today. We have no proof. These cells have shown they can exert paracrine effect. Look at that. Very important. Like an endocrine effect, like the local tissue reaction effect. That's called paracrine effect. And then furnish from this site. The other organs have shown us, we orthopedic have not, but the liver transplant, all other people have, other organs have shown that there is a paracrine effect. But we are not able to still show in orthopedics, like the stem cell in avian, paracrine effect. The stem cell in avian, we have poor vascularity. Stem cell die. Many have paracrine effect before the day. Before the day, they can produce some paracrine effect, but we don't have proof. Stem cells have to convert into osteoblast, and we need to increase vascularity and osteogenesis potential of the stem cells. We need to stimulate the stem cells, to grow inside and then convert into osteocyte and osteoblast. We should be able to increase the vascularity as far as the environment is concerned. So there is a possibility of bone marrow stem cells which are cultured and adipose stem cells which are also cultured. Both have some promising effect. They have advantage of promising angiogenesis, increased vascularity, so that they can grow and they can survive. Whatever the death has occurred, whatever the cells, suppose 10, 20 cells are there, they should be able to survive with this atmosphere, and they need vascularity and they need angiogenesis. So there is possibility of getting angiogenesis in these patients. If both are combined, this procedure can have synergetic effect on angiogenesis and osteogenesis. It is definitely proved in the animal model in 2018. So we'll have to do, there is no human trial. There is a possibility of implanting there is possibility that we do have a vascular endothelial growth factors. We can implant along with these people. So you can increase vascularity by this growth factor.
Sir. Sir. Hello.
Yes.
Sir.
Yes, go ahead.
Yeah, sir. I'm starting little again. You are just ending in 1 minute, so I'm starting it again.
Okay.
You can take time, sir. Whatever slides are remaining, you can go in detail.
Yeah. Give me the link.
Yeah. Sir, you can proceed, sir.
Yes, yes. The next couple of, not now, a few slides, the external biophysical non-surgical procedures also are there, which are known as pulse electromagnetic field stimulation, extracorporeal shockwave therapy, hyperbaric oxygen therapy, and bone marrow injection. Either you can inject inside the joint or wherever you want to. That's the way people are using this. So pulse electromagnetic field stimulation, looking at the analysis, looking at the data everywhere, there is a study which is done. Pulse electromagnetic field may have a role in the management of early vascular necrosis. The paucity of clinical studies into this technique indicates a need for further study, and still we do not have a proof on this condition. The extracorporeal wave therapy. There is a system, systematically analyze this evidence. We could conclude, this is the large data which collected on PubMed, that this therapy, that is extracorporeal shockwave therapy, could act as a safe and effective method to improve the motor function and relieve the pain of the patient with osteonecrosis of the femoral head, especially those at very early stage. Image relieves that bone marrow edema was significantly relieved, but necrotic segment could not be reversed after therapy. So necrotic remained there only. So we do not have increased vascularity there or in any osteoblastic action or repair, repair is there. So that is the reason. Still, this is also not evidence based. 1 minute. Huh? Hello. I'll call you webinar में 15 मिनट में बोलता हूँ. Okay. Oxygen therapy has been also very popular in USA. There are two types. Individual can be there, the chambers can be there. So this what has been reported with this oxygen therapy is it improves definitely oxygen, reduce edema, improves venous drainage. But still, this is not. This is very early phase to say that stage 1 or stage 2 maximum we can use hyperbaric oxygen therapy. This usually you have to do it for at least a sitting of 45 to 1 hour, 1.5 hours, and the sitting has to be minimum 90 days, sometimes 60 to 90 days. Definitely there is a role of osteotomy. Unfortunately, this has not picked up in our country. But there is most of the European countries, I think this is the osteotomy has been picked up very well. When the lesions are very small, you can do this. So there are two types of osteotomies are. Rotate the necrotic segment or a collapsing segment, whatever the collapsing segment or necrotic, you turn the head into non-weight-bearing area and bring the good normal head under the acetabulum to take the load. It can take the load. Additionally, this may reduce venous hypertension and intramedullary pressure. That is a secondary effect after the osteotomy. But the main effect is the rotate the area. There are two types of osteotomies. One is transtrochanteric rotation osteotomy. Second is intertrochanteric varus or valgus. Depends on where the segment is, which I'll tell you, where the segment of the head is. Sometimes it is combined with flexion and extension, but the transtrochanteric osteotomy is very morbid operation and it is not the best. It is only the best in his originator man. So all the people tried after he came into the market. So everybody had a lot of bad reports. So today there is transtrochanteric rotation osteotomy is not done. That is Sujioka osteotomy. Examiner might ask you, I'll come to that Sujioka osteotomy, how it is done. Ideal patient for osteotomy is young, preferred male, non-obese, non on steroid. There should not be osteoporosis. Small segment, I told you 120, less than 120 degrees, that is some small segment. That is a segment of the carpal and no acetabular involvement. That should be the ideal candidate. Is it technically demanding? That's why our people don't want to do it. Any technical demanding, we don't take it. Subsequent conversion THR may be difficult if there is excessive translation, then it becomes difficult. So this is Suzuka. He actually came to India and did one or two osteotomies in India, in the central part of the India with Dr. Babulkar. So what the basic osteotomy, I'll tell you. We do the trochanteric osteotomy. The trochanteric osteotomy, keep the flap up, the gluteus medius and minimus and piriformis is lifted up. We open the capsule completely, and around 10 millimeters below this area, we do endotrochanteric osteotomy and put a Steinman pin on this fragment, and this, whatever the segment is here, now this segment is completely rotated on the posterior pedicle. So this is the anterolateral approach, and look at this pedicle here, and this segment is now here. This segment is here. So this complete rotation has been done. Wherever you want the segment, you take it, but you require complete capsular release. Then only the head fragment has to be completely free in your hand. With the Steinman pin, you should be able to rotate in flexion, rotation, whatever the way you want. So Suzuka had a good result, but unfortunately, they were not replicated by others. And this is the data coming from USA. This is a Mayo Clinic data. Suzuka rotation osteotomy delays hip degeneration patient with AV and stage 2 disease. Maybe role in selected patient difficult to perform and high potential morbidity, including non-linear. Results are variable with success is only 40%. So today, as far as you are concerned, I am concerned, everybody is concerned, we don't do this osteotomy. This is I picked up from his own, and I had opportunity to meet Suzuka in 2004, I think 2003 or 4. I was invited by the Japanese Orthopaedic Association, a celebration of 75th year. So I was invited as a guest, and I had a 2 or 3 days I stayed with him. Regarding the osteotomy, the other osteotomy, whether varus or valgus, this is a little busy side, but you will understand. It's very straightforward. The decision about the osteotomy to use often depends on the location and the size of the lesion. I told you 120 degrees, less than a small lesion, less than 1/3 lesion of the femoral head, maybe less than that. For example, if the lesion is located on the medial side, medial femoral head, then you do varus osteotomy, which is ideal. Varus producing osteotomy will shift the weight bearing axis from the medial femoral head into unaffected lateral side of the femoral. So medial will be converted into lateral side. However, if the lesion is located anterior superior, which is very common with VC in India, anterior femoral head, then valgus and extension you have to do. Producing osteotomy is required. Here the weight bearing axis of the patient hip will be shifted from anterior superior portion to posterior medial portion of the femoral head. That's the way these two osteotomies are described. So this is the valgus osteotomy, where the lesions are anterior superior, here, anterior superior. So with valgus and extension osteotomy, the lesion will go behind, medial and posterior. So this is one example this is the angle braid plate. The lesion was this, and you look at this one, lesion has healed fairly well. This is not, I have not done, this is from the book I have picked up. So varus osteotomy, where the lesions are medial. So this is the varus osteotomy, and this is after osteotomy healed up and taken out. So these are the two small indications where the lesions are very small, young patient, possible. I think Dr. Bagu does a lot of osteotomies from Delhi. Hip surfacing. It has gone down because metal on metal has become problem. Now we don't do much of the hips resurfacing. There is only one implant still approved by FDA across the world. That is from the Smith & Nephew company. That is from Macmillan Hip. Still people do, but it's less than 1% of the now. So young active males, non-dependent on steroids. Acetabular cup diameter should be minimum 50 millimeter. That's why most females are not indicated. So the acetabular diameter is very small, 46, 48. Why? Because the smaller diameter deformation has taken place and metal release have been much more higher, and that is the reason it has come to disrepute. So now we don't use less than 50 millimeter for resurfacing. Stage 4 with arthritis. Do not operate in stage 1, 2, 3. Unless patient develop arthritis, the femoral head has to be strong enough to take this load. Many people have suffered because fracture neck femur. Reason is they operated in stage 3. How much to remove? Patients should be ready for follow-up on regular serum cobalt and chromium level, then only operate them. Females try to avoid this surgery. This is the Macmillan. Now, 14 years follow-up of this patient. When I was in Mumbai, I did a couple of them, and this is one of the patient of an avian. Totally, we have already discussed quite a lot, but I'm just going to get only one slide here. Advanced osteonecrosis. That is the stage 4, 5, and 6. Something like stage 4 in Arlet, Ficad Arlet. Choice of depends on the surgeon choice, whether uncemented, cemented, hybrid. But these are young patients. We'll try to do more and uncemented. Highly cross poly on ceramic, ceramic on ceramic, ceramic on metal. Depends on the patient's pocket and as well as what is your experience and what you are comfortable. So all these bearings are good. These are some patients of my own, which are long-term follow-up. This is a ceramic head. That is ceramic head and ceramic and cross-linked poly. That is the not delta ceramic. This was non-delta ceramic. This was Biolox Ford, which is I done about 15 years back. This is a highly cross-linked poly and metal. This is a straightforward primary type. And this is ceramic on ceramic with a slightly larger head. So this is the bearings you can use. You can use whatever you are comfortable. Some miscellaneous procedure which I told you, bipolar orthoplasty. This is one report coming from our India itself, which is 6 or 7 years follow-up from Pune. That is Dr. Dudani's paper. He did a lot of bipolar when in the non-arthritic, that is stage 3, collapsed head, but the stabulum was good, and he did couple of them with a good results. Orthodesis, I think no patients today want no patient wants orthodesis now today. But it's a very young and liberal class. Probably orthodesis may be a good choice, liberal class. Excision orthoplasty, resection orthoplasty, they don't do well. They're very unstable. They don't. Young patients do not like. Young patient may like orthodesis, but may not like a resection. Acrylic cement injection, I told you, and titanium implant rods, I told you. Now, prognosis of this condition in 2 slides, I will tell you, depends on the stage of the disease. More than 50% will need surgical procedure within 3 years of diagnosis. Whatever you do, 50% patients with subchondral fracture will develop a contralateral avian. Age older than 50 are not going to do well. Advanced stage, at the time of the day you diagnose stage 3, these people will go on progressing. And non-modified risk factor like cortisone, avian, and immunotherapy, they will not do well. Thank you for the attention, Srikunj Bhai.
Thank you, sir.
I hope I have made
Thank you very much, sir.
Thank you, sir.
Yes,
Thank you,
sir.
sir.
Yes, sir. Okay. We'll meet tomorrow, sir. Yeah.
Okay.
Thank you very much.
Thank you.
Bye. Thank you so
Bye,
much,
sir.
sir. Thank you.
Thank you, sir.
Bye, sir.